Anemia, in layperson's terms, means that there is less hemoglobin in the blood, fewer red blood cells carrying oxygen in the body. During parturition, this condition ultimately results in decreased oxygen supply to vital organs, uterus, fetus, and placenta, thus impairing the mechanisms that cause labor contractions. 45% of women worldwide are anemic, roughly half of them due to iron deficiency anemia, caused by inadequate iron in the diet. Since pregnancy puts a high demand on iron stores, and women who have had multiple pregnancies and perhaps began in a slightly anemic state are further depleted with each pregnancy. Thus a woman with severe anemia is already running low on fuel, running on empty. Management of anemia during labor can be divided into 4 stages, and these 4 stages are: Stage 1, Stage 2, Stage 3, Stage of puerperium. During Stage 1, the treatment modalities include special precautions, comfortable position on the bed, light analgesia, oxygenation prevents fetal hypoxia, strict asepsis. During the second stage of labor, the treatment part includes intravenous methergine 0.2 mg or 20 units of oxytocin in 500 ml RL intravenous, and 10 units of intramuscular are given. During third stage of labor, the patient is kept under intensive observation and blood loss must be replaced by fresh packed cell, but it must be kept in mind that soon after delivery of the fetus, there is a high amount of blood going back to the maternal circulation, blood from the distended uterus. If the patient was on blood transfusion, the chance for fluid overload is high, and the patient will be in danger to develop peripartum cardiomyopathy. Some obstetricians propose that, if the woman in labor needs a blood transfusion, the first thing is to give intravenous furosemide Lasix to decrease the intravascular compartment so that to give a room for incoming blood, although this intervention, furosemide, can impair fetal maternal circulation during the puerperium, the patient is advised to take complete bed rest. Any sign of infection must be detected and treated as soon as possible. A continuation of postpartum iron medications until the patient restores, and also a proper diet planning is a must. Severe anemia, normally defined as hemoglobin Hb 70 grams per liter, can result in circulatory decompensation and increased cardiac output at rest. The added stress of labor and blood loss, whether normal or excessive, can lead to circulatory shock and death. There is also evidence to suggest that anemia is associated with prolonged labor, lower wound healing capacity, and a greater likelihood of having sepsis, another key cause of maternal mortality. Since anemia is the most common disorder in pregnancy, so proper screening and treatment of any such disorder along with diet planning and proper care of the mother during the course of the condition is necessary. Postpartum hemorrhage, the loss of more than 500 ml of blood after delivery, occurs in up to 18% of births and is the most common maternal morbidity in developed countries. Risk factors for postpartum hemorrhage include a prolonged third stage of labor, multiple deliveries, episiotomy, fetal macrosomia, and previous history of postpartum hemorrhage. Early recognition, systematic evaluation, treatment, and prompt fluid resuscitation minimize the potentially serious outcomes associated with postpartum hemorrhage. This condition must be approached just like other resuscitations. Start with the ABCs, large bore intravenous access, and place the patient on a monitor. A thorough pelvic and placental examination is done to determine the etiology of the postpartum hemorrhage. If atony is diagnosed, start with a bimanual massage. Uterotonics can then be used to encourage the uterus to clamp down. For every birth, 20 units of oxytocin and 1 liter normal saline should be given intravenously. Additional medications include misoprostol, carbaprist, and methylorgonavin. The dosing of and contraindications to these medications can be understood through the following table. Oxytocin to be administered 20 to 80 U once intramuscularly without any contraindications. Misoprostol to be administered 1000 mcg once rectally without any contraindications. Methylorgonavin to be administered 0.20 mg every 2 to 4 hours intramuscularly, but is contraindicated in hypertensive patients. Prostaglandin to be administered 0.25 mg every 15 minutes intramuscularly, but is contraindicated in asthmatic patients. If uterotonics are not achieving their desired effect, the antifibrinolytic tranexamic acid, TXA, may be considered to indirectly stabilize clot formation by inhibiting plasminogen from working to break down fibrin. It is reasonable to activate a massive transfusion protocol If there is persistent bleeding and concern for anticipated blood loss is expected to lead to hemodynamic instability. Other mechanical approaches to stop bleeding include uterine tamponade. Bleeding refractory to these therapies requires invasive interventions such as embolization of the uterine arteries, or, ultimately, a hysterectomy needs to be performed. Postpartum hemorrhage cannot be consistently predicted and requires emergency providers to quickly recognize this complication and be prepared to initiate therapies unique to this patient population.